Cysticercosis is a parasitosis caused by a helminth Taenia solium. The life cycle of Taenia solium begins with the eggs, which are found in human feces, which are ingested by the intermediate host, mainly pigs. These eggs give rise to the encysted cysticerci in the muscles of the pigs. On consuming undercooked pork, humans acquire the encysted cysticerci, which are released in the human small intestine and give rise to the adult tapeworms. The adult worms release eggs into the human feces. Cysticercosis is an infection caused by the accidental ingestion of these eggs by the humans. Leading to development of larvae in human small intestine and their migration to multiple organs like the muscles, liver, heart, brain, and eyes, and subsequent cyst formation. Thus, humans serve as both the definitive host and the intermediate host of this parasitic helminth. As reported in the literature, there are various presentations of cysticercosis in the human eye. For example, in the subconjunctival space, anterior chamber, vitreous, subretinal space, ocular muscles, and the orbit. The treatment options available vary from observation in cases of calcified cysts, medical management, and surgical removal. In this video, we have presented the successful management of a subretinal cyst which underwent in toto removal via pars plana vitrectomy. A 41-year-old male presented to us with recent onset of vision loss in his left eye with a best corrected visual acuity of 20/400. On examination, he had a total exudative retinal detachment with a subretinal cyst. The B scan was suggestive of a cystic structure with a hyperreflective echo indicating a scolex. Neuroimaging showed a calcified lesion in the brain, thus ruling out active neurocysticercosis. Thus, a 23-gauge sutureless pars plana vitrectomy and cyst removal was planned. After placement of ports and initial core vitrectomy, induction of posterior vitreous detachment was done. This led to nasal retinal break formation owing to abnormally thick vitreoretinal adhesions. After complete vitrectomy and membrane removal, the cyst was brought into the vitreous cavity through the nasal retinal break with the soft tip cannula to avoid damage to the ball. A fluid needle was used to remove the cyst in toto through an enlarged sclerotomy while increasing the infusion pressure. After fluid air exchange, the retina was attached, endolaser photocoagulation was performed around the retinotomy, silicone oil was injected. The presence of cysticercosis was confirmed histopathologically, revealing tissue consisting of a cyst-like structure lined by a double-walled invaginated membrane. The cyst wall was also positive for periodic acid Schiff stain. The post-operative period was uneventful, with vision recovering to a best corrected visual acuity of 20/50 and an attached retina throughout noted under oil. Early surgery is recommended for cyst removal to prevent secondary fibrotic changes and possible migration of the cyst, which could lead to further damage.